right here with the carotids. Is that right? And we've really already talked about this, but this is kind of a good review because remember we were talking about pulses and feeling for pulses. We were talking about palpating the different ones. Remember that we do them together at the same time because we're comparing, correct? You don't want to do, the only pulses that you don't feel at the same time are the carotids because you don't want to knock somebody out, hopefully. Because you don't want to include their oxygen supply. That's the best thing. Of course, if you don't feel a pulse, an absent pulse, and it could be a couple of things. It could just be technique. It could be that you're actually occluding the pulse. So you've got to make sure that you're very, very careful. Hopefully you learn that in your CNA program, that you're very, very careful when you're palpating pulses not to occlude them. You want to just feel very gently. But an absent pulse that's not technique related is a bad thing, right? That means that there's probably a stenosis or a blockage. So you really want to make sure that you do hear or feel a pulse. Okay? There is a term called a bruit. B-R-U-I-T. A bruit. Now, up to this point, we've been talking about palpating our pulses. A bruit is when you can actually use the bell of your stethoscope and listen over the carotids for a pulse or a sound. A bruit is a bad thing, though. Okay, bruit is bad, so remember, B, bad. Bruit, bad. A bruit is a swishing sound or a blowing sound that you can hear with the bell of your stethoscope over the carotid arteries. But if you do hear it, you don't want to hear it. If you do hear it, what that's telling you is that there is a blockage or a narrowing of that artery. Okay. There are other places that we listen for bruits. One is over the abdomen, because you remember from anatomy that the aorta goes down, right, through the abdomen. So if you, when we're going to get to the abdominal assessment, you can actually turn your stethoscope, listen with your bell. But if you hear a blowing or swishing over the abdomen, that is also could be a bad thing, because that means that there's a blockage in that aortic area, and that's a very common area for aneurysms. So if you know of anybody who has an aortic aneurysm, then you will probably hear a blowing or a swishing sound. Okay? The jugular veins, we're not talking about arteries now, we're talking about veins. The jugular veins, if you remember from your anatomy class, there are two sets, right? Internal and external. The internal is deeper, and it runs alongside the carotid artery. Okay, the external, of course, is more external to the skin. Jugular vein distension, you'll see it abbreviated on a lot of tools, a lot of assessment tools, as JVD. That means jugular vein distension. Your jugular veins should be flat when you are lying or you're sitting. You should not be able to see your veins. Have you ever seen weightlifters and when they sit up or they stand up, you see these bulging veins in their necks, and everybody thinks they're just manly and it's wonderful. That is an awful thing. And as healthcare providers are the ones that, we see that. We don't think they're big and bad. We think, oh, you're getting ready to die. That's what you're getting ready to do. Because what that means is there's so much pressure being applied on those veins that they're sticking out. That's called jugular vein distension. So when they're sticking out like that, that is a bad sign. You don't want to see jugular vein distension. Okay? The way that you test that on your patient, if they're lying flat in the bed, is to raise the head of their bed 30 to 45 degrees. So if you raise the head of their bed 30 to 45 degrees and their veins start to distend, they start to poke out, then you know that their blood pressure, the pressure on their heart is high. Okay, and it can be from a lot of causes. Of course, it can be from your stenosis or hardening or blockage, anything like that can cause jugular vein distension. What's that term, that big fancy term when you have plaque cholesterol? You know, atherosclerosis, right? Atherosclerosis. So that's when you have the plaque that's covered the veins. Okay, so jugular vein distension is a bad thing. So next time you flip through and you see these big old athletes with their pulses and their necks bounding, remember that that's not a good thing. We don't want to emulate that. Okay, any questions about that? When you're checking for veins, you're also looking for clots in those veins. Okay, not only are we palpating for the pulse itself, but we're palpating for tender areas, we're palpating for dilated veins. The word varicosity is a fancy term for a dilated or a broken vein. Some men and women, especially those who stay on your feet a lot, you'll start to notice that in your legs, your veins are broken, or you can actually see the veins on the surface of your feet. I've got some really bad ones in my feet. And of course, as healthcare providers, they recommend that we wear what? Pressure stockings or elastic stockings. And of course, they're hot and miserable, and I hate them. So that's why my feet and legs look like they do. But you really should. Phlebitis, if you don't know, is an inflammation of a vein. Phlebitis is the inflammation of a vein. The problem with phlebitis is that it promotes the formation of clots. It promotes the formation of clots. Now, Homan's sign is a test that you can do to check to see if there is a clot in the leg. Some of your deep vein thrombosis, DVTs, blood clots. The way that you test that is you take one hand and you prop it under their knee as they're lying in the bed, and you kind of dangle their knee in the bed, and then you have them to dorsiflex their foot. If they dorsiflex their foot while you're supporting their knee, they dorsiflex their foot and they scream out in pain, then that is a sign there may be a clot in their leg. That's called a positive Homan sign. So you support their knee with one hand, you have them dorsiflex their foot. If they scream out in pain, then you need to have further testing done. That's called a positive Homan sign. The most accurate way to tell that someone has a blood clot is actually to use a tape measure and measure calf size. If it starts to increase, what do we say? What was phlebitis again? Inflammation of the vein. So if it's inflammation, what's that vein doing? It's swelling. It's starting to get larger. So what would that tell you about the calf size? It's going to get larger, isn't it? So as we measure, if we continue to measure, what we're going to see is that that leg is going to start to increase in size. Usually, DVTs are one-sided. So what can you do? You measure and compare the two legs, right? If you measure the calf size of the right leg and it's significantly larger than the calf size of the left leg, then that's another sign that we may have a blood clot going on. And of course, the best way, the most 100% way, is to get an ultrasound. And they'll ultrasound that leg and they'll see a clot in that leg. And then there's a whole process where you put them on bed rest, and you'll get to that eventually. But when you're doing your physical assessment, start with that Homan sign. Have them dorsiflex their foot, see what happens. Who would be most at risk for developing blood clots, do you think?
Surgery.
Okay, certain conditions, heart conditions, surgery patients, sedentary patients, smokers, people who are bedbound, people who are obese or overweight, people with clotting disorders. Okay. Pregnant women. Pregnant women are high risk for blood clots. What else goes along with female that they always are on the news all the time? What do we have? What do we take to prevent getting being a pregnant woman? Yeah, birth control pills are also a really bad problem with blood clots. Okay, especially the estrogen-based products. All right, so there's a lot of things to consider when you're thinking of it. I mean, most of the people that you come in contact with in the hospital are going to be at risk, at some risk. It may be a mild risk, but at some risk for blood clots. What's the best way to prevent them from occurring? Do what with them? Get them up and move, right. Get them up and ambulate as quickly as possible. If you've been in the hospital lately, they don't let you lay in a bed. I had a C-section with Ben, and I was up the next morning. Catheter was out, I was up. And so that you don't lay in the bed anymore. There is no laying in the bed. Even with any of your surgeries, most of your surgeries, you're up and moving. And that's the best way to prevent blood clots from forming, because you're moving that circulation, you're moving that blood around. Okay? So blood clots are a problem. We always have to consider that with our patients. All right, let's talk about the heart sounds. Have you got your stethoscopes with you again today? Hopefully. We're going to listen to heart sounds now. Okay. All right, the first thing you're going to do, everybody look at this slide really quick, and then we'll listen to some heart sounds on each other, and while you're doing that, I'll pull it up. Okay? Now, first thing that you have to do, and this is the same thing with your lung sounds. Remember with lung sounds, I said that you have to go back to our anatomy. We have to remember our certain positions, right? So with heart sounds, you want to make sure that you remember there's mid-sternal and then mid-clavicular. Okay? Because here's your clavicle, so mid-clavicular. A lot of our heart sounds are to the left of the mid-clavicular line. Okay? So when you're thinking about that, that's what you're going to remember in your mind. Remember we talked about the apical pulse being down here under the breast line? Everybody, did you try to find those spots on somebody at home? Hopefully you did. One thing to remember is that before the age of 6, between 4 and 6, the apical pulse is it's in the same spot, in the same intercostal space, but it's a little further to the mid-clavicular line. And then before the age of 4, it's higher up. It's in the third to fourth intercostal space. Okay? Okay, so as we age, that apical pulse is going to be closer to where it is in an adult, in that fifth intercostal space. Okay? What did I say about, what is that spot also called? You remember? PMI, or the point of maximum impulse. And what does that mean? Remember what I said that means? That's where what? That's where the heart touches the chest wall. That's the closest part to the chest wall. So if you suspect that somebody has a murmur, what do? You have them turn to that left side. It throws the heart closer up to the chest wall, and you can hear. And which part of the stethoscope are we listening with? Do you remember? The bell of the stethoscope is what it's going to hear for deeper heart sounds and murmurs. Okay? So if you suspect, or you just, maybe it's an older person, and you really can't hear their heart beating clearly. Okay? They have a really thready pulse, and you're really having a hard time hearing that heart. Have them roll to their left side, because it's going to throw the heart closer to the chest wall, and you're going to be able to hear a lot easier that way. Okay? All right, let's look at this next one. I love this next one. It's one of those pictures. Okay? There are 5 heart sounds. Okay, so we talked about 26 lung sounds. There are 5 places for heart sounds that I want to make sure that you can identify. One way to remember that is all people enjoy Time magazine. Okay, that little mnemonic. All people enjoy Time magazine. The first one is the aortic sound. It is in the right second intercostal space. It is the only one that's on the right side. Okay? The only one that's on the right side. So when you remember how we located the angle of Louis, and then we found that supracostal notch, suprasternal notch, and then we moved over to the second intercostal space. Okay, to the right, the second intercostal space on the right is going to be your aortic sound. Okay, so that's the aortic area. If you follow your finger across to the second intercostal space on the left, that is pulmonic. The third intercostal space, if you move your fingers down and fall into the third intercostal space, is Erb's point. Erb's point means that S1 and S2, your lub and your dub, are heard equally loud. Okay, they're heard the same. They sound the same pitch and everything. Okay. The fourth intercostal space, if you drop down again, is tricuspid. And then your last one is mitral. It is close to the apical pulse. The mitral sound is right beside the apical pulse in the fifth intercostal space, mid-clavicular line. The mid-clavicular line. So of course you have to lift the breast up to here under the fifth intercostal space. So you've got aortic, pulmonic, tricuspid, Erb's point, tricuspid, and then mitral. Okay? All people enjoy Time magazine. Okay? You can remember that? All people enjoy Time magazine. Okay. Let's look at these different heart sounds, and I'm going to let you listen with each other while I pull up the actual sounds of murmurs and stuff. Of course, we talked about the left side of the heart has the most effective assessment because it is the loudest. It is the loudest. S1 and S2 are your lub and your dub. That's when you're listening to a heartbeat, you're hearing lub dub, lub dub, lub dub, lub dub, lub dub. There are some extra heart sounds, S3 and S4. Mostly those are heard in young children and in athletes. Those sound like, and if you have your picture packet, if you looked in your picture packet, there's a thing where it describes S3 and S4 as sounding like Tennessee and Kentucky. Did you see that? S3 is Kentucky, 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 and then Tennessee is your S4. Tennessee, 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 Tennessee. So we're going to listen to those in just a minute. You're also going to hear S3 and S4 sounds in people who have heart conditions, such as heart failure, congestive heart failure. You're going to hear S3 and S4. Okay? There's more blood pumping through the heart. It's having a harder time pumping. There may be some blockages, some stenosis, and it creates those extra sounds, those extra heart sounds. So young children, athletes, and people who have heart conditions are when you're going to really hear S3 and S4. So it's not something that you want to hear in just the normal, average adult. Okay? There are some other abnormal heart sounds. A murmur, and that's a swishing or a blowing sound heard anywhere in that lub or dub. It may be a low murmur. It may be a high murmur. We rate our murmurs. Remember how we talked about pulses? We were feeling for pulses. You also rate a murmur grades 1 to 6. Now you are not going to have to do that. That is above you, well above you. That's a practitioner level. But just for your knowledge, a grade 1 murmur is barely heard with the stethoscope. I mean, you barely hear it. You really have to know what you're listening for to hear that. Whereas a grade 6 murmur, you can walk in the room and hear the murmur from the doorway. without a stethoscope. That's how loud the murmur is. And of course, that is a bad thing. That is a very, very, very bad thing. Okay? A murmur is caused by the blood flow is backing up through a valve instead of going through without backflowing. The valve does not close properly, and so it's backing up. You're having some backflow. Okay, so the valve did not close properly, so the blood, whereas it's supposed to just go forward and into circulation, backflows through that valve. It also can be caused by hardened valves or diseased valves. You can actually hear a murmur. People who have murmurs may also have what we call a thrill. And a thrill is a palpable sensation. If you lay your hand over the heart area, the palm of your hand, which is the most sensitive part, remember the palmar surface is the most sensitive part of your hand. If you lay the palmar surface over their chest wall and just feel, you'll feel have you ever felt a cat purring? How they feel when they're purring? That's what it feels like. It's a very slight vibrations, that feeling. That is, people who have murmurs have thrills. Thrills are not a good thing either. That's telling me that there is something going on, that there's backflow through that valve. And remember, we've already talked about a bruit, right? We talked about how to listen for that with the bell and stethoscope. Now, I do want to say one thing about a murmur. Murmurs are very common in newborns. So if you're ever listening to a newborn, and we'll talk about this again next summer when I teach you OB, newborns do have a murmur that is a non-life-threatening murmur, and that will most of the time correct itself. It's just a result of those neonatal valves, heart valves that had to be present when they were in the womb, not closing quick enough. And so you hear a murmur that's not life-threatening, it's not anything major. But if you're ever listening to a newborn and you hear a murmur, don't panic. They don't usually get worried about those until they're a few months old. Okay? All right. Let's practice. Hopefully this will. All right. Let's do it. Let's see if we can hear an S3. There's the extra beat. So there's an extra sound after the dub. There's love and the dub dub. Love, the dub dub.
Now when you check their pulse, how would you count that?
It's very difficult to count.
Is that one of the ones that's considered?
It is abnormal, and that's one of those definitely. Remember what I talked about? You don't want to be checking people with the electronic blood pressure machine when they something like this. It's definitely. But the second and third beat, which is kind of one.
But you said this would be
Normal in children and young adults and athletes, and is normal. Young children, athletes. But it's abnormal if you hear this and they're not an athlete or young, then you can suspect that there's something
like how young?
I'd say up to teenage years, through puberty, you may hear it because they're more active. Through puberty. All right, let's listen to the fourth heart sound. That's an extra sound on the love side. anybody in here have mitral valve prolapse? Or know somebody who has mitral valve prolapse? Let's listen to mitral, and that's when, of course, the mitral valve collapses on itself whenever blood's going through. It's kind of blowing or swishing. That's that murmur that I was talking about. It kind of blows there at the end. Okay. Mitral regurgitation. Very distinct. Yeah, that's just blowing. That's what it sounds like. Very difficult to hear your love and your dove, isn't it? Because the blood flow is regurgitating back to the valve. So it's going to hear like that. You're going to hear that blowing sound. Let's see if we can hear some diastolic sounds. Aortic regurgitation. We do have somebody in here with aortic regurgitation. Hear it? You can hardly hear the love of the dove. Okay. Patent ductus arteriosus. You hear this a lot on newborns whose ductus arteriosus didn't close when it was supposed to. Can't hardly hear the heart. Again, it's all due to the blood flow regurgitating back. So those are murmurs. Let's see if there's anything else that would be good here. Atrial septal defect. Here it's just kind of a rub or a blow. It's not very clear. You don't hear your love dove, love dove, love dove. Now, you're not at the level of being able to say, oh, that is aortic regurgitation. You're not going to be able to hear. You're not going to be able to say that. But I do want you to know the difference in that and a typical loved up that you can hear distinctly. Okay, you think you can do that? You think you can tell that that's not normal? Okay, that's what I really want you to do.
And aortic aneurysm, would it sound similar to
It would sound like that. Regurgitation, yeah, sure would. Okay. All right. I forgot that this site also had lung sounds. Let's see if they'll, we were having trouble finding some the other day. Let's see if we can practice. Those are pretty good examples. Practice. Remember I said, I think it sounds like Rice Krispies. They say opening Velcro. That's wet sounding. And remember, what's the difference between crackles and bronchi? Which clears by cough? Bronchi clear by cough. Crackles do not. So if you say, oh, I can't hear, can you cough for me? And you still hear this, then you know it's crackles and not bronchi. Wheezes. Asthma. Strider with your croup. Remember we used to sell the baby? That was having some trouble. Alright, so again, if you want to write down that site, that's a good site for you to go to, that auscultation assistant. Alright, were you able to find those 5 sites? So in checkoffs, when we do our checkoff, one thing that we're going to ask you to do is locate the 5 heart sounds. Now, we're not going to say, well, what are you hearing? But we want you to be able to know where they are. So you can say you're all people enjoy Time magazine. All right? Everybody thinks that they can do that? Okay. Capillary refill time. What should our capillary refill time be? Less than what? 3 seconds. Less than 3 seconds. Okay, so the way that we check capillary refill time is to squeeze their toe or their skin. You know, you can actually do it on the skin surface. You don't have to do it on their fingernail or their toenail. Okay? So you're blanching the nail or the skin, and you're watching to see how quickly color returns, and that's capillary refill time. What is that telling me? Why do I do that? Circulation. Oxygenation as well. If they have poor oxygenation, then they're going to have a very sluggish capillary refill time. Okay? So it should return within 3 seconds. Okay, this is another one of those nice little pictures for us, the neurovascular assessment. Just some 5 Ps, just to remember. And this kind of goes along with your pulses, and then we also did the tactile sensations the other day. So it kind of goes along with all of that. The 5 Ps, pain, pulse, pallor, paresthesia, and paralysis. If you have trouble with these, if they can't feel pain, if they have a very thready pulse, if their skin tone is not the same in that extremity, you know, if they have paresthesia or where they can't feel it or they can't move it, then we know that we have some kind of damage to that area. Okay, so any questions about heart and lung? All right. Why don't we take a little break, about 10 minutes, and come back, and then we'll start reproduction. Now, you are going to be as a regular registered nurse on the floor. You are not going to be typically doing a full reproductive exam. And really the only time you're going to be doing a reproductive exam is if you suspect there is a problem. So when you go to clinical, this is not something you're going to be doing unless as you're bathing the patient or as you're, feeding them, cleaning their Foley or something, you notice something's wrong. All right? But we do know that, let's talk about the basic things about females. The external genitalia, you are not going to be, of course, doing internal genitalia. That is something for a physician or a nurse practitioner. But external genitalia, when would you notice problems? What would you be doing? Bathing them, dressing them, changing them, something like that. Okay? You are looking at the breast tissue. When you do a breast exam, you want to divide the breast into 4 quadrants with the nipple being the center, and then you're palpating with your fingertips. Again, remember that is the most sensitive part of the hand. Palpating with your fingertips in a circular motion around the breast. And what are you feeling for? Knots, lumps, anything that's abnormal. And I've got this little star down here to remind us, because that's my 4 quadrants, to remind us that we need to make sure that we are palpating in the axilla area. This is called the tail of Spence. The breast tissue, if you think about it, it almost looks like a little tadpole. You've got the breast tissue itself, and it's got a little tail that goes underneath up in the breast, up in the axilla. That is where majority of breast cancer is found, is in the tail of Spence. Okay, so really make sure, and there is a picture in your picture packet of the breast tissue. You've got to remember to palpate that area. And I say females, but males get breast cancer as well. Did you know that? That males do get breast cancer. Males do have breast tissue, so they should be also palpating periodically that breast area, that breast tissue area. Okay? It changes all the time. When you're teaching your patients about self-breast exam, of course, that's something that should be done monthly no matter how old you are. The current recommendation for mammograms is over the age of 40, although some physicians, if you have a family history, are saying as young as 35. It depends on your insurance, though, whether or not they're going to cover it. But when you're teaching patients about doing self-care or self-exams, you need to make sure that they understand that just because they're older or maybe they're past menopause does not mean they stop doing self-breast exams. Okay, that's something that's very important. And you'll have a lot of older women that don't go back to a gynecologist after they've had their babies or after they've hit menopause because they don't feel the need for it. And that's when you get a lot of people getting in trouble, get things missed. So make sure that you really encourage that when you're educating. The pubic area, of course, pubic hair, you're also looking at the labia, majora, minora, making sure that the labia are intact, that there's no excoriation. If you've got somebody who's had a catheter and they've had a catheter in for a long time, have you ever seen people that have had catheters in for a long period of time? If you work in a nursing home, a lot of people have catheters and they get nasty and that labia will start to break down, that tissue will start to break down. And you can imagine if you've got tubing that's constantly rubbing up against that sensitive skin, it's going to tear and have some excoriation. So checking for that, you're checking for any lumps or nodules, discharge. So when you're bathing a person, when you're cleaning that area, you need to make sure that you kind of inspect that area to make sure there's nothing abnormal. Okay. All right, men. You are inspecting, of course, the penis, the shaft. If they have not been circumcised, the foreskin, you can retract it, but make sure that you pull it back up. I don't know if you know this or not. And when we do OB and when we do newborn assessment, you'll do that with me this coming summer. I won't even let you do a newborn retract his foreskin, because if you don't get that foreskin back in place, it acts as a tourniquet and it will cut the blood supply off to that penis, and I don't think you want to be responsible for that. Okay? All right, so always make sure that if you've got an uncircumcised patient, that foreskin is pulled back up. Bad would be very bad. Okay? The scrotum, very gently inspect the scrotum, palpate the scrotum. Now, every year I have a student that gets all up in arms because they go to do this exam or bathe the patient. And you all talked about this in CNA. I know you did. As you're bathing a male patient and their penis gets hard, and then all these little girls who get all blushed and, they get all flustered. You treat it professionally. Don't giggle. Don't run from the room screaming. Don't do anything like that. You just treat it very professionally. You can pull the covers back up. Just talk to them like nothing's going on. Okay? It will go away. You hope. Okay, normally the left testicle is lower than the right. You want to make sure, in young children, one of the things that we make sure of is that both testes have distended. A lot of newborns, when they're born, both testicles have not distended, and they have to distend. They have to come down into the sac or descend into the sac. Otherwise, they may have to go in and actually do surgery, so you want to be really careful of that. Okay, and again, you're looking at the same thing with the female. You're looking for swelling, lesions, discharge, anything unusual. All right, let's talk about Tanner stages. And I wrote it up on the board. I wrote your 5 different Tanner stages up on the board. So if you want to jot those down really quickly, we're going to talk about what's specific in each one. When we're looking at Tanner stage of patients, This goes all the way through adulthood. You want to make sure that they are in the appropriate tanner stage for their age. Okay, bless you. Some people mature faster than others. Correct? But sometimes their tanner stage may be abnormal because of a hormonal imbalance or an endocrine imbalance. Okay, so tanner stages are very important to note. I don't know if it's the hormones in the chicken. You know, people say that all the time. It's the hormones in the chicken. I don't know if that's the case or not. But we do know that people do tend to mature faster than others. All right, stage 1. And when we're talking about tanner stages, we're talking about those secondary sexual characteristics. Breast, pubic hair, testicles, and scrotum. Okay, so as we're going through each of these stages, I'm going to tell you what they should look like in that stage. Stage 1 is your pre-adolescence. Pre-adolescence. Typically, that's before age 8. Okay, my little stepdaughter is 8. That she would fall into this category. I have a 7-year-old little girl. Of course, she would fall into this category as well. In this category, in pre-adolescence, there is no pubic hair. And there are very tiny breast buds. Very small breast buds. You've seen little children, their breast tissue, there may be a little bit of a raised area there, but not a true breast there. Same with boys. No hair around the penis or the scrotum. The skin of the scrotum and the penis appear to be the same color. There's no difference. That will change. All right. Stage 2 is early adolescence. This is your 8 to 12-year-olds. And that's a wide range. Now, I've got some people who have told me before that they've had to put a bra on their child before the age of 8. You know, I mean, again, I don't know if it's the hormones in the chicken or whatever, but some people just do mature quicker than others, right? But 8 to 12 is typically what we consider early adolescence. They start to develop sparse pubic hair, both boys and girls. Sparse pubic hair. The breast tissue starts to mound. And when I say mound, you know, it starts to make a little bit of a mounding shape. This is your little training bras. Y'all remember those? My stepdaughter came with hers the other day, and it was just this tiny little thing, and I thought, I don't think I ever went to that. I think I went past that. I don't ever think I have a training bra. But they were cutest little thing. Little training bras, you know, because the breast tissue does start to mound. Okay? Mostly girls. Mostly girls. For boys, the scrotum starts to change in texture. Okay? And the tissue starts to thin. The scrotum starts to change in texture, and the tissue starts to thin. All right. Stage 3 is adolescence. 12 to 13 years. There's an increased amount of pubic hair. Breasts for females tend to enlarge in shape. Okay, they're no longer just those mounds. They actually start to look like a breast at that point. You're past the little training bra stage now. Now, your book says that menses begins at this point. Again, everybody starts at a different time. I was 9 when I first started my period. And a lot of you probably were around early starters. Anybody an early starter in here? Yeah. So, it depends on the person. It's genetic. It can depend on condition. Everybody develops differently. But menses should have begun by this time. One thing we're gonna also talk about this summer is if you have not started your menses, your period, by the age of 16, then it needs to be investigated. There's something wrong. Okay, so 12 to 13, you should have begun by that point. Anybody a late starter? Some people start late, really late. So, okay. 13, okay. Okay, stage 4. This is late adolescence, your 13 to 17-year-olds.
How about boys with
The 12 to 13, really all you need to know is that there's just an increased amount of pubic hair at that point. Okay, stage 4, your late adolescence. The amount, again, of pubic hair is, at this point, the same as an adult. The difference between this stage and adult stage is that the hair has not spread to the thighs yet. I don't know if you ever really paid attention to that when you were this age. But that is actually a Tanner sign, that the hair has not spread to the thighs. That's in late adolescence. Okay? Of course, the breasts are more pronounced, and the scrotum darkens. Now, we talked about it changing in texture. Now the skin darkens. So the scrotal sac is darker than the penis itself. Y'all are doing really good. Nobody's giggled when I said penis. Every year somebody has to make some kind of joke. Y'all are very professional. I'm very proud of you. Okay, stage 5. This is adult. Really the only difference between this and late adolescence is that the hair has now spread to the inner aspect of the thighs, and the nipples on a female protrude. Up until this point, the nipples should not have really protruded. What are they getting ready for? Breastfeeding. They're getting ready for nursing. Right, exactly. Okay. Uh-huh. Mm-hmm. You can actually feel the bud. If you're actually palpating in that area, you can actually feel the breast bud. Fatty tissue is more spongy, but a breast bud, actually there's a little hardened piece feeling underneath there. It feels like a little pea. That's a good question though, because you're going to see that. You're going to see that in some younger girls. Children who have, I work at the pediatric hospital. We have a lot of young children with diabetes, type 1 diabetes. That's an endocrine issue, so that affects their stages of development. So you're going to see this, especially when we go to peds. If I give you a child that has some kind of chronic condition, you're going to start seeing this. But it's very important to recognize that, because if they get behind on their Tanner stage, significantly behind on their Tanner stage, then they need some testing done. There's something going on, okay, with their growth and development. So very important to remember. Okay, elimination. So we're moving down the system. The bladder. You're palpating the bladder. That's your tool that you're going to use in your toolbox, is palpation. If you have never felt a full bladder, I suggest you do it on yourself. Wait till you have to go to the bathroom. And lay down on the bed. It's right above the symphysis pubis. You're going to feel a very spongy, hard area. right there, that's a full bladder. Now, you're laughing, but it's the truth. If you really never felt a full bladder, that's what you need to do, is wait till you have to go to the bathroom and then just very gently palpate over that bladder, and then you'll see what it feels like. And then do it right, and then do it again right after you go to the bathroom, so you can tell the difference in a flat bladder and a full bladder. Now, something else that you might not know is that we always have a small amount of urine in our bladder. It will never be completely and totally empty. If it was completely and totally empty, it would collapse on itself. Okay, and so we never want it to do that. So you're always going to have a small amount of urine in your bladder. Urinary retention, of course, is a problem with a lot of people, a lot of older adults especially, who have lost the sensation to go to the bathroom. If they've had surgery or if they've had a catheter inserted, it's very difficult to retrain yourself to go back to the bathroom after having a catheter put in. We typically give them anywhere from 6 to 8 hours to go on their own. And if they're not able to go on their own, then we'll start in and out catheterizing them. And we don't want to put the catheter back in, but we'll go in and empty it and then try again for 6 to 8 hours. But it is hard because your body gets used to something letting the urine out without you having to put forth any effort. Okay, so those muscles in that area, those Kegel muscles, are very important. All right, do you remember at the very beginning when we were talking about the way that we do our assessment? Remember I talked about that, palpating, percussing, and we start with inspection, and we palpate, percuss, and then auscultate, with the exception of one area. Remember I talked about that? And that was the abdomen. Okay? When we are in this area, you always want to auscultate first.
I was going to ask you, so do we go and listen to them first before we get them up and take them to the bathroom? Get them up and take them to the bathroom?
It will. You're exactly right. You do want to auscultate first before you get them up and go to the bathroom. Very good question. Because moving and sitting on a toilet is also going to stir up sounds. Very good question. Okay, so this is the one area that we do it differently, and we auscultate first. Now you can inspect, because all that is just looking. You're not touching or doing anything. Inspection is just the process of looking. But the next thing you want to do is auscultate. So you're using the diaphragm of your stethoscope, and you're dividing the abdomen into 4 quadrants. Okay? The umbilicus is your midpoint. That's the center of the quadrants. Okay? So you label your umbilicus. You've got right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. That's how you do that. Okay? When you're inspecting, of course, you're looking at the skin, you're looking for scarring. Of course, the new type of surgery right now is laparoscopic surgeries. Most everything can be done lap. And you're going to see these little bitty tiny scars. C-section incisions, like I have a C-section scar. Anybody who's had any kind of abdominal surgery, they may have had an open incision, so you're looking for those kind of things, scarring. The contour of the belly, making sure that it's even. When you're palpating, what are you feeling for? Like masses or any kind of hardened areas. Okay, palpating for those kind of things. You can also, remember we talked about the aorta, and we use the bell of the stethoscope over the aortic area to listen for bruits. We talked about aneurysms. This is one of the times when you're auscultating and you're listening for bowel sounds, and you're going to hear that gurgling sound. You can also listen for bruits over the aortic area. And of course, we don't want to hear bruits, right? Those are bad things. If you hear a bruit, a swishing sound over the aorta, that means that there's a blockage. Okay? Now, when you're auscultating the abdomen, you want to listen, and you want to make sure that you listen in all 4 quadrants. All right? Until you hear bowel sounds. Up to 5 minutes. Okay? If you are not hearing anything, you stay in that one quadrant up to 5 minutes. After 5 minutes, if you still don't hear anything, then you got to report it, because it could be what we call an ileus, and an ileus means that the bowel is not moving. Okay, the bowel should constantly be moving something. Even if you haven't eaten, there's going to be gas in that area, there's going to be liquid, something. You should always hear something. Now, it may be hypoactive. You may not hear it as strong as you would if they had just eaten. They would be very hyperactive and very active, but you want to make sure that you hear something. So an ileus, you've listened in that quadrant for up to 5 minutes and you hear nothing, then you need to report it, and that is a very serious thing. If the bowel stops moving, you're in trouble, okay? Because it can become necrotic and die. We don't want that to happen. Okay, so for up to 5 minutes for an accurate assessment. All right, so get with your partner and listen to their tummy. Divide yourself up into 4 quadrants and listen in each quadrant, okay?
Listen for a bruit. You mean under the
Copy of it. Here it is. No, right. Follow 1, 2, 3, and 4.
After. If y'all be eating breakfast, then that's going to stir up a lot of stuff, right?
Sounds.
Each quadrant, if you don't hear anything. Yeah, if you hold your stethoscope on there and you hear then you can move on. Right, okay. If you don't hear anything, you stay in that spot.
Oh, that's right.
I don't go low enough on you.
Really?
That sounds okay. I'm working then.
Really?
One of my residents this weekend. I didn't need to.
I just ate.
Continuous food.
I'm sorry.